Welcome to Immunology and Immunohematology Made Easy channel. Paper Summary Notes. Least incompatible units for transfusion in autoimmune hemolytic anemia. Should we eliminate this meaningless term? A commentary for clinicians and transfusion medicine professionals. Lawrence D. Petz. Much has been written about the detailed serologic approaches that are available to select the optimal unit of RBCs for patients whose autoimmune hemolytic anemia, AIHA, makes necessary more complex compatibility test procedures than usual. These must appear baffling to clinicians who have not had detailed training in the laboratory aspects of transfusion medicine. Compounding the problem is the fact that, when clinicians do seek consultation with the transfusion service, they are sometimes merely informed that a least incompatible unit is available. This term, devoid of a scientific definition and cloaked in mystery, merely adds to the confusion. Synopsis. Lawrence Petz, 2003, reported in Least Incompatible Units for Transfusion in Autoimmune Hemolytic Anemia, that least incompatible units for transfusion in autoimmune hemolytic anemia, should they eliminate this meaningless term? A commentary for clinicians and transfusion medicine professionals. Least incompatible unit is a term that should be discarded for the following reasons. Hemolysis caused by anti-A and anti-B is avoided by providing blood of identical or compatible ABO type. In warm antibody AIHA, the autoantibody in the patient's serum will generally react with all RBCs tested, masking the presence of the anti-JKA. Undetected alloantibodies may be the cause of increased hemolysis following transfusion. Main highlights. The fundamental message offered is that clinicians have a responsibility to understand the principles of compatibility test procedures in patients with AIHA, and transfusion services have an obligation to provide to the clinician information concerning the extent and effectiveness of the compatibility test procedures employed. Physicians who are responsible for the care of patients with AIHA should be familiar with the following aspects of compatibility testing in patients with AIHA so that they may communicate effectively with the transfusion service personnel. The most important technical problem faced by the transfusion service regarding patients with AIHA relates to other RBC alloantibodies, which are capable of causing hemolytic transfusion reactions. Least incompatible unit is a term that should be discarded for the following reasons. It is not an official term in immunohematology, it is not defined in transfusion medicine nomenclature, it is used differently by various transfusion services, it is not the critical aspect of compatibility testing in AIHA, and its use does not useful convey information regarding the extent of compatibility testing performed. Summary notes. General principles. In the day-to-day operation of a hospital's transfusion service, compatibility testing is performed to select units of RBCs that can be transfused without risk of a hemolytic. Hemolysis caused by anti-A and anti-B is avoided by providing blood of identical or compatible ABO type. The most important technical problem faced by the transfusion service regarding patients with AIHA relates to other RBC alloantibodies, which are capable of causing hemolytic transfusion reactions. These alloantibodies are developed as a result of previous transfusions or pregnancies and may be directed against antigens of a number of blood group systems, such as Rh, Kell, KID, and Duffy. Undetected alloantibodies may be the cause of increased hemolysis following transfusion, which may be falsely attributed to an increase in the severity of AIHA. In warm antibody AIHA, the autoantibody in the patient's serum will generally react with all RBCs tested, masking the presence of the anti-JKA. Patients with warm antibodies. A number of approaches are available for selecting donor RBC units for transfusion of patients who have warm autoantibodies. These include routine testing of the patient's serum against a RBC panel, diluting the patient's serum before doing compatibility testing, performing adsorption tests, which will remove the autoantibody but not alloantibodies from the patient's serum, and supplying phenotypically matched RBC units. A number of approaches are available for selecting donor RBC units for transfusion of patients who have warm autoantibodies. These include routine testing of the patient's serum against a RBC panel, diluting the patient's serum before doing compatibility testing, performing adsorption tests, which will remove the autoantibody but not alloantibodies from the patient's serum, and supplying phenotypically matched RBC units. If a weakly reactive autoantibody and a strongly reactive alloantibody are present, the differences in the strength of the reaction of various cells of the panel will make this evident. There is no assurance that a patient's alloantibody will react more strongly than the autoantibody, so additional tests are necessary. Dilution technique. A serum dilution, such as 1 in 5, may be selected arbitrarily for compatibility testing in the hope that this will dilute out the autoantibody but not the alloantibody. The optimal adsorption technique for detecting alloantibodies in the presence of a broadly reactive autoantibody is the warm autoadsorption procedure. In this technique, some of the autoantibody is eluted from the patient's RBCs, and these cells are used to adsorb the autoantibody from the patient's serum at 37 degrees. When autoadsorption tests are not feasible, the optimal procedure is the allogeneic adsorption technique, that is, adsorption of autoantibody from the patient's serum with several samples of allogeneic RBCs of varying phenotypes. For example, for Rh, K, and JKA antigens, would only provide protection against a limited number of alloantibodies that can cause hemolytic transfusion reactions, and would not preclude the necessity of pre-transfusion adsorption studies. Whether implementation of this approach is cost-effective and feasible at many hospitals and blood centers has not been determined. If the intention is to emphasize providing phenotype-matched units, it must be determined that the blood supplier could readily provide such units, and it must be recognized that adsorption studies will be required in cases where the patient's RBCs cannot be phenotyped. Compatibility testing in cold antibody AIHAs. Compatibility testing in cold antibody AIHAs is less labor-intensive than in warm antibody AIHA. If the transfusion service is not able to perform testing strictly at 37 degrees, 1 or 2 cold autoadsorptions should be performed, which will not remove a high-titer cold agglutinin completely but are likely to eliminate reactions that occur at 37 degrees. In paroxysmal cold hemoglobinuria, the autoantibody will not react at 37 degrees. In this disorder, the autoantibody is unusual among AIHAs in that it very often has specificity for a RBC antigen, almost always the P antigen. Transfusion of RBCs of common P types should be provided because patients with PCH often have severe hemolysis, and waiting for P or PK RBCs is likely to delay a needed transfusion. Successful transfusion of patients with PCH has been reported by numerous authors and, almost certainly, the transfusions were of P plus blood. Procedure for a patient with AIHA. The term least incompatible unit seems to be used very frequently. It is not defined in the medical literature and is used differently by different transfusion medicine professionals. Such a procedure for selecting least incompatible units must not be considered an acceptable alternative to the techniques described above for selecting donor units for transfusion of patients with AIHA. This process as the sole means of selecting RBCs for transfusion of such patients will not reliably detect alloantibodies and is unacceptable in modern-day transfusion medicine. This is a dangerous practice and should be abandoned, except in extremely urgent settings in which there is not time to perform adequate serologic tests. However, some transfusion services appear to use least incompatible unit in another context. They perform adequate serologic studies as reviewed above and select donor units for transfusion on that basis and go on to cross-match the selected units with the patient's serum. All such cross-matches will be incompatible because of the patient's autoantibody. The transfusion service may choose the least incompatible unit even if no specificity of the reactions can be ascertained. In either of these settings, there is no disadvantage to selecting the unit that reacts least strongly. This may seem to provide some additional assurance that an alloantibody has not been missed. This is unlikely after an appropriate search for alloantibodies, as described above, has been carried out. Because the term least incompatible unit is not formally defined and does not represent the critical aspect of compatibility testing in AIHA, use of the term in discussion with clinicians can lead only to confusion and a lack of confidence in the safety of units selected by the transfusion service for transfusion to a patient with AIHA. Responsibilities of the clinician. A discussion between the attending physician and the transfusion service should take place as soon as it is evident that a patient with AIHA is being considered for transfusion. The clinician should discuss the compatibility tests to be undertaken by the laboratory with the above outline of compatibility test procedures as a guide to adequate pre-transfusion testing. The clinician must balance the risk of withholding transfusion for that length of time with the benefit of added safety that complete testing provides against alloantibody-induced hemolytic transfusion reactions. Only a few % of all hospitalized patients have RBC alloantibodies, so that if transfusion is extremely urgent, the lesser risk may be to transfuse rather than waiting for completion of the compatibility testing. Even in very urgent situations, there is almost always time to perform at least some of the recommended compatibility test procedures, such as use of the dilution technique and/or partial RBC phenotyping, which will provide some measure of safety. Responsibilities of the transfusion service. It will be the responsibility of the transfusion service to initiate the communication because the diagnosis of AIHA may first be made during compatibility testing for a requested transfusion. The transfusion service should feel obligated to supply the clinician with information about the compatibility test procedures performed. If the transfusion service selects RBC units for transfusion after excluding the presence of alloantibodies by adsorption procedures, the clinician should be so informed. If the transfusion service goes on to select a least incompatible unit from among the selected units, this may possibly provide some additional measure of safety, but is not the most important aspect of the compatibility testing. Informing a clinician that a least incompatible unit was selected fails to provide adequate information and may result in the clinician avoiding transfusion in a situation where transfusion is needed. If the transfusion service merely indicates to the clinician that least incompatible ABO-matched units will be supplied, this should be considered unacceptable. Recommendations concerning the use of the term least incompatible unit. Least incompatible unit is a term that should be discarded for the following reasons. It is not an official term in immunohematology, it is not defined in transfusion medicine nomenclature, it is used differently by various transfusion services, it is not the critical aspect of compatibility testing in AIHA, and its use does not useful convey information regarding the extent of compatibility testing performed. Employing the term may suggest that use of ABO-matched least incompatible units is an acceptable alternative to performing an adequate serologic evaluation before transfusion of patients with AIHA, when it is not an acceptable alternative. Least incompatible unit is a term that is entrenched in in-house jargon. It should not be used in discussions with attending physicians and, if used at all, should not be permitted outside the confines of the transfusion service. It is time for transfusion service personnel and clinicians to discuss issues surrounding transfusion of patients with AIHA in informative, scientific ways. Until we meet again in another paper. Thanks for watching.